a registered nurse and director of cardiac services, and it's my pleasure to welcome you here this evening. Tonight, Dr. Mody is going to talk to us about women and heart disease, but before we begin, we have a couple of housekeeping items I'd like to go over. If you have a question, please utilize the Q&A box, and we will do our best at the end of the lecture to answer as many questions as possible. If you have a question that's a little bit more personal in nature and you'd like to have us answer it perhaps personal or off the line, go ahead and feel free to email myself or Dr. Mody, and we would be happy to get back to you as soon as possible. So it is now my pleasure to introduce Dr. Vatsal Mody. Dr. Mody is an interventional cardiologist at San Antonio Regional Hospital. He graduated from Government Medical College in South Gujarat University in India. He completed his cardiovascular fellowship and interventional fellowship at LA County and University of Southern California Medical Center, aka USC. Dr. Mody is currently serving as the medical director of the Coronary Care Unit at San Antonio Regional Hospital, where he does an absolutely phenomenal job, and the nurses are so appreciative of everything that he does. Dr. Mody is married. He has 2 children, and in his free time, he enjoys playing with his dog and tending to his fruit orchards, which are absolutely amazing. So please join me in welcoming Dr. Mody.
Thank you, Alison, and that was a very kind, generous introduction, and I really thank you for that. And my name is Dr. Vatsal Mody. I'm an interventional cardiologist at the San Antonio Regional Hospital in Upland, California. And today I have been given the opportunity to talk about women and heart disease. So moving on, we'll start with the lecture now and start with this topic, which is indeed very intriguing, women and heart disease. On March 8th, it was the International Women's Day, and the main theme was to break the bias. Women should not be treated unequally, and everything should be done to take care of the bias which has been working against women. Today's lecture is going to be dedicated to all the women in the world. Heart disease in women is very common. Cardiovascular disease is a worldwide leading cause of death in women. So the question comes, are women different from men? Certainly so, absolutely yes. The biological differences and the gender differences between men and women are obvious. Women naturally have been born with ovaries, which secrete estrogens, which have a complex influence on the cardiovascular system. And the gender differences which are brought on by the society, which brings on a different kind of psychosocial stressor on women, is obviously different from men. So these complex interaction between the biological differences and the gender differences between men and women account for the variation in the prevalence, presentation, and natural history of cardiovascular disease between men and women. There are so many trials that occur all over the world, not only in US and other countries. And you would be surprised to see that women are underrepresented in clinical trials. And conclusions are made from these clinical trials, and then they are applied equally to men and women. And there is no allowance for sex disaggregation, diagnostic and management strategies. Even though there are differences, these strategies are not differentiating between men and women. Women are more likely to experience delays in diagnosis, to be treated less aggressively, and to have worse clinical outcomes. Thus, cardiovascular disease in women remains understudied, underdiagnosed, and undertreated. When we say we want to remove the bias, that's what we want to address. We want to have more women representation in the studies so that they can be studied well and appropriate recommendations can be made for them. So heart disease in women include coronary artery disease, heart failure, pulmonary hypertension, cardiomyopathy, and cardiovascular disease in pregnancy. Today, we'll talk about coronary artery disease and cardiovascular disease in pregnancy. And we will not be discussing much about the heart failure, pulmonary hypertension, and cardiomyopathy. So coronary heart disease or coronary artery disease afflicts 6.6 million US women annually and remains the leading morbidity and mortality threat in women. And of these, 2.7 million have a history of heart attack, and greater than 53,000 women died of a heart attack. And there are many more who are hospitalized for a diagnosis of acute coronary syndrome, which includes a heart attack and chest pains due to decreased blood flow to the heart muscle. Regardless of age, within the first year and also within the first 5 years, more women die as compared with men. And many more will have heart failure and suffer a stroke as compared to men. Compared with men, women are commonly present with non-ST segment elevation myocardial infarction and non-obstructive coronary artery disease. Now, these are a lot of complex words that I've thrown in there: non-ST segment elevation myocardial infarction, non-obstructive coronary artery disease. But don't worry, I will be elaborating on these subjects in just a few more minutes. We'll delve deep into the topic. Women are also more likely to have unusual pathophysiological mechanisms of coronary artery disease, such as spontaneous coronary artery dissection, known as SCAD, or coronary artery spasm, known as CAS. Compared with men, women with acute coronary syndrome and those after coronary revascularization have longer hospitalizations, higher in-hospital mortality, manifest more bleeding complications, and endure up to 30% more readmissions within 30 days after the index hospitalization. So what is the influence of age in heart attack in women? Acute coronary syndrome in young women seems distinctive because premature coronary heart disease is relatively rare in these days, in this group. Limited existing data on the frequency of heart attack among young patients reveal that each year many women less than 55 years of age are hospitalized with a heart attack in the United States. Recent data of the heart attack in patients who are 65 years of age demonstrate nearly twofold higher crude 30-day hospital readmission rate in women compared to men. Now, recently we have seen that there has been a decline in the event rates in older women. However, this decline in the event rates in young women is absent. In fact, troubling trends of worse risk factor profiles and higher mortality among younger compared with older women persist, with continuing reports of excess in hospital early and late mortality compared with men. Consistent evidence suggests an age-sex interaction whereby younger women are particularly at a high risk of mortality after a heart attack. As compared to men, women are usually older when they present with their first heart attack, around 72 years of age, as compared to 65 years in men. The older age of onset in these women could be due to the protective effect of the estrogen during the younger age. The estrogens have a protective effect because they affect the vascular endothelium in a beneficial way. However, despite the cardioprotective effects of the endogenous estrogens, it has been found that giving estrogen hormone for the primary prevention of coronary heart disease or coronary artery disease in the post-menopausal women have been convincingly negative. Therefore, the Women's Health Initiative has provided evidence indicating that the post-menopausal women hormone therapy is not suitable for the prevention of coronary artery disease or coronary heart disease. And therefore, initiation of such therapy of hormone replacement in the postmenopausal women for either the primary prevention or in secondary prevention of cardiovascular disease is not recommended at the current time. Primary prevention means that you've never had an event and you are taking these medications to prevent the first occurrence of the heart attack. And secondary prevention means where you already had a heart attack and now you're going to try to prevent another one from happening. Ethnically diverse women present with their incident MI at a younger age than white women. The prevalence of heart attack is higher in the Black women in all other racial and ethnic groups. Of particular interest is that Black women have higher incidence of sudden cardiac death on the first manifestation of the coronary artery disease than white women. And the survival rate of the Black women after out of hospital cardiac arrest is about 1/3 of that of white women. So in Black women, particularly, there is more evidence of heart attack in younger age. They have more than 3 risk factors when they present with their heart attack. They are usually have more comorbidities. They have more mortality after the heart attack. So we have to focus our attention towards the Black women in particular, and they seem to be the most compromised as far as the cardiovascular care is concerned. At the time of presentation, older Black women and younger Black women have more than 3 risk factors. Similarly, the Native Americans women also have more than 3 risk factors. We also focus our attention toward the Asian Indians who also have similar presentation with more risk factors and a poorer outcome as compared to the white women. Young Black women have higher hospitalization rates as compared to the white women. Across all the groups, therefore, we should pay attention to the ethnically diverse, particularly the Black women, the Hispanic women, the Native American women, and the Asian Indian women. We also found from the American College of Cardiology National Data Registry that women from all ethnic backgrounds were less likely to undergo percutaneous coronary intervention and coronary artery bypass graft surgery. Multiple studies have demonstrated disparities in the referral of the Black women for coronary angiography, coronary perfusion therapies compared to white women and Black men. Even after all the differences were controlled, the Black women are least likely to be offered the reperfusion therapy or coronary angiography. Similarly, when it comes to secondary prevention, the Black women seem to be more compromised. The rate of medications that are used for secondary prevention, such as aspirin, lipid-lowering therapies such as statins, counseling for smoking cessation, is lower among Black women. Similarly, referral for cardiac rehabilitation after these events is lower in the Black women. So switching gears, now we'll move on to the pathophysiology of the heart attack. And again, there's a difference between men and women. So coronary pathology interacts with the biological sex characteristics of women to produce differences in plaque characteristics. And we'll soon get into what is a plaque and what does it mean when we say rupture of a plaque or erosion of a plaque, and what does it mean when we say coronary artery spasm and spontaneous coronary artery dissection. This is a very nice slide that you can see, and it clearly shows traditional risk factors, specific risk factors for women, and the different types of pathology that are involved in the ischemia that is produced by various pathological mechanisms. So here, if you see coronary thrombosis or thrombus formation on a ruptured or eroded plaque is shown. We'll talk about coronary vasospasm. We'll talk about spontaneous coronary artery dissection as one of the mechanisms producing heart attack in women. And then we'll also talk about coronary microvascular disease. Another interesting situation is where the women get what is called as the broken heart syndrome or Takotsubo cardiomyopathy. So here we have shown in this diagram the structure of the heart along with the arteries which travel on the surface of the heart. So for example, here, this artery which travels on the right side is known as the right coronary artery. And this artery which travels on the surface of the heart is known as the left anterior descending artery. And similarly, there's a third artery which is known as the circumflex artery. So these are the main distribution arteries that travel on the surface of the heart. And here, if you remove the heart from the picture, then you see that just like the roots of a tree, you have the bigger roots, and then you have smaller branches which penetrate into the myocardium and form a fine capillary meshwork. And this is what constitutes the microvascular bed for the coronary circulation. Moving on to the pathology, if you take that one artery and you take a section of the artery, on the far left, you will see that this is a cut section of the artery. The innermost layer is known as the intima, the middle layer is known as the media, and the external layer is known as the externa. And here in the center is the lumen, where the blood cells and the cholesterol particles are flowing. As you see, these cholesterol particles can then penetrate the inner lining and then get deposited in the space below the intima. And that leads to formation of what is known as a fatty streak. And as time goes by, there is more deposition of the material, and body then mounts an inflammatory response, and the body cells then come to the site and eat up these cholesterol particles, and in the process, they die. And as more and more cells accumulate and die, there's a lot of inflammation going on there, and you get a cap which is formed by the intima, which forms the cap of the plaque. There can be a lot of necrotic material there from the dead cells, and also there's calcium deposition within the plaque. What is known as a vulnerable plaque is a plaque where there's a lot of inflammation and the cap on the plaque is thin, which can then rupture. And when it ruptures, all the material in the plaque can get exposed to the blood that's flowing through the lumen. Here we can see this is a cartoon where you have plaque on the top, and this is the lining covering the plaque, and that's where the plaque ruptured. The necrotic material got exposed, and the blood was flowing there, which then, because of the interaction between the blood and the necrotic material, there was clotting of the blood, which started here, and you will see all the red blood cells start aggregating here and eventually form a clot or a plug, and no more red blood cells can pass through, and the artery is completely occluded, which you will see as a 100% blocked artery. And that causes the muscle that is supplied by that territory to not have any blood, and therefore not have any oxygen and the nutrients, and eventually that causes the heart muscle cells to die, and that condition is known as a heart attack. So it's very essential that we do something to unclog this vessel and reestablish the blood flow so that we can save the heart muscle and prevent all the consequences that occur from dead heart muscle. When we talk about terms like STEMI and non-STEMI, and one wonders what these terms mean. And therefore, just a short description of what is a ST segment elevation MI. Here you will see a normal complex, And in this complex, you'll see that this segment is known as the ST segment. And normally, the ST segment is in line with the baseline. Now, when the artery gets completely blocked and there's no blood going to the heart muscle, the whole thickness of the heart muscle lacks the blood, and that produces certain changes which causes the ST segment to get elevated. And this is known as the ST segment elevation pattern that you see in a 12 EKG. So whenever a patient goes to the hospital, to the emergency room, the first thing that is done is an EKG is done. And if you see ST segment elevation, then it is known as the ST segment elevation myocardial infarction. It is an emergency. Time is muscle. You need to be able to do something to be able to open up that artery. Here at the San Antonio Regional Hospital, we are a STEMI center. And every hour of the day, 7 days a week, all throughout the year, we are available to provide that service to any patient who walks through our doors with an ST segment elevation, such that we can take them to the cardiac catheterization laboratory and then immediately do an angiogram and be able to visualize the site of the blockage in the artery and do what is known as angioplasty and stenting to be able to open up that artery to reestablish the blood flow to that muscle. And this helps to save the amount of muscle that gets injured because of the heart attack, prevents heart failure, prevents arrhythmia, prevents death. So we are able to provide this service to our community over here, and usual benchmark is that you want to be able to open up the artery within less than 90 minutes. And we are proud to say that we are accomplishing that in majority of the cases. The other group of patients with a heart attack is the non-ST segment elevation myocardial infarction, where a plaque rupture can happen or a plaque erosion can happen, and the blood clot forms at the site that this happens, but some amount of blood is still able to pass through, and therefore the artery is not completely or 100% blocked. And in that situation, the ST segment gets depressed, and this is known as the ST segment depression in a non-ST elevation MI. So non-ST elevation MI, again, depending on how the patient is presenting, if they're very unstable, if they have significant drop in their blood pressure, then we will still take those patients to the cath lab on an emergency basis. But if they're overall stable and not having a major compromise, then they can be treated with medications and then later taken to the cath lab to perform coronary angiography to find the site of blockage, for which we can again open up with the various interventions that we do. Sometimes you see only the T wave, which is shown here as inverted, and that T inversion could also be a manifestation of the non-ST segment elevation myocardial infarction. Here's a normal EKG. You can see that the ST segments are isoelectric, meaning they are at the baseline, and this patient has a normal EKG. And here you can see these ST segments that are markedly elevated in the various leads. And based on where the ST segment elevation is present, we define it as the front of the heart or the bottom of the heart or the side of the heart, mainly the left ventricle, which is affected by the heart attack. And this would be an example of an ST segment elevation myocardial infarction, which is an emergency, and that should be treated emergently. We do not wish to lose any time. So in fact, when the paramedics reach the patient's home and they see this kind of EKG, they'll call the emergency room, the cardiologist will be called in, no matter what time of the day, the cath lab team will be called in, and as soon as the patient hits the door, they are taken to the cath lab and immediate coronary angiography is performed, the site of blockage is found, and interventions are done to open up the artery to protect or further damage to the heart muscle. Here is an example of a non-ST segment elevation myocardial infarction. There's your plaque there. When the rupture of the plaque occurs, at that time, the necrotic material gets exposed to the blood starts clotting. But you can see that even though there's a clot there, some amount of blood can still get through. And that condition, you get a non-ST segment elevation myocardial infarction, which again, as I explained, could be treated with various options, either emergently or on an elective basis. Here's an EKG that you would see where you have ST segment depressions in all the leads, and this would constitute an EKG in a non-ST segment elevation myocardial infarction. So what are the various mechanisms that leads to these kind of conditions? So plaque rupture, plaque erosion, calcific nodule are some of the mechanisms which I explained that in plaque rupture, the plaque cap actually breaks and the necrotic material from underneath the plaque comes out in contact with the blood in the lumen. In plaque erosion, only some of the cells from the surface are removed, but the plaque doesn't actually rupture and the necrotic material doesn't come out into the bloodstream, but this still causes the blood to clot, and that causes an obstruction to the blood flow and thereby causes a heart attack. So plaque rupture is by far the most common cause responsible for the heart attack in majority of men and women with a fatal heart attack. However, it should be noted that plaque erosion is another mechanism for coronary thrombosis without rupture of the plaque and is many times seen in women. So although the plaque rupture was responsible for like 75% of patients with a fatal heart attack in men, only 55% of women had such kind of plaque rupture. Autopsy shows that there's increased prevalence of plaque erosion in women compared to men, particularly in younger women. And this is of particular interest because even though they had the heart attack, and when you do the angiogram, you don't find that there is the plaque which is causing significant obstruction, and therefore you can find a heart attack without the presence of obstructive blockage in the artery. And this is also known as MINOCA, where there is MI in the absence of no obstructive coronary artery disease. So plaque erosion accounts for 27% of women with the STEMI and 31% of non-STEMI in these studies. Patients, the acute coronary patients with erosions are younger, they have less severe obstructive coronary disease and less often present with STEMI than those with the plaque rupture. Plaque rupture is especially rare in the premenopausal women, perhaps suggesting a protective effect of the estrogens. Additionally, 7 and 32% of women with heart attack have no angiographic demonstrable obstructive coronary artery disease. And this is what I explained as was MINOCA, where there was a heart attack, and when you did the angiogram, there was no significant obstruction in the vessel. Coronary artery spasm is also another mechanism. Here you can see that there is spasm in the artery, and there's no plaque that was seen. And when the spasm occurs, you can form a blood clot within the vessel at the site of the spasm, and that can lead to the heart attack. The other mechanism that we talked about was coronary artery dissection, in which the inner layer gets torn and then forms a flap, and the flap causes obstruction to the blood flow. And if you noted that there was no plaque in either the coronary artery spasm or the coronary artery dissection, where the disease was found in a normal looking vessel. Here's a video of an angiogram. This little tube here is known as the catheter, and we are injecting iodine contrast into this artery, which is the right coronary artery. And when you see the black dye going down the vessel, you can see that it is going down all the way to the end of the vessel without any problem. And when you induce spasm in this vessel, which is known as a provocative test, and you inject a medication known as acetylcholine, you can see that severe spasm is induced here. The vessel is completely blocked. The contrast is not going down further. And if this situation were to happen, then the patient would be having a heart attack because no blood was going down that vessel, and all that area of the heart muscle would be devoid of blood. Therefore, coronary artery spasm can cause a heart attack too. So coronary artery spasm is a well-known phenomenon for recurrent chest pain episodes at rest with associated transient ST segment elevation. So it may be that the patient may be getting a chest pain, and then you do an EKG and you can catch the ST segment elevation, yet at other times when the spasm is gone, the ST segments may come down. It is still a rare mechanism for heart attack. Now, cigarette smoking is a major risk factor for the coronary artery spasm. And possible triggers include variation in the autonomic activity, use of cocaine can cause this, ephedrine alkaloids can cause this, and many other drugs can cause this. So provocative testing with acetylcholine or ergonovine or hyperventilation during coronary angiography can be helpful in diagnosis the coronary artery spasm. Coronary artery spasm plays a significant role in the development of a heart attack. In patients with acute coronary syndrome from coronary artery spasm, 25% had no obstructive culprit lesion when the coronary angiography was performed. Coronary artery spasm was present in almost 50% of the patients who underwent the provocative testing with the acetylcholine. Now, if you are able to provoke spasm, it's an important finding. So provoked coronary artery spasm is an independent predictor of major adverse cardiac events. The incidence of recurrent or persistent angina is high in the long-term follow-up of the patients with coronary artery spasm. However, the rates of heart attack with coronary artery spasm and death from coronary artery spasm is less common. Moving on, we talk about the spontaneous coronary artery dissection, which is also known as a SCAD. The SCAD is a very rare cause of heart attack that occurs more frequently in women and should be suspected in young women, particularly who present with the acute coronary syndrome without a typical atherosclerotic risk factor profile. So the true prevalence of SCAD is unknown, but there is data that suggests that 0.2 to 4% of patients undergoing cardiac catheterization, and you may find them to be having a spontaneous coronary artery dissection as the cause of their heart attack. So particularly after pregnancy, in peripartum period and the postpartum period, and in women with the use of oral contraceptive use, connective tissue disorders, and certain diseases which are known as fibromuscular dysplasia, spontaneous coronary artery dissection can occur. And therefore, having this history is very important. So generally, if you are having a woman of childbearing age, had pregnancy and just delivered, and is in the postpartum period and starts having severe chest pain, then it should not be ignored, because these patients may be having a heart attack due to spontaneous coronary artery dissection, and that could become fatal if no appropriate care was provided. In some cases, there are no existing conditions that are there when this SCAD happens. SCAD can cause heart attack, arrhythmias, and sudden cardiac death. And most of the times it is one of the vessels that is involved, but multivessel involvement of SCAD is known. It is also very tricky to take this, to manage these patients, because if you take them to the cardiac catheterization laboratory and try to introduce a wire into the coronary artery to do your angioplasty, you may enter into a false lumen, and you may actually make the situation worse. And so many a times, the conservative treatment of not doing angioplasty or stenting allows the patients to heal the dissection on its own. But if the patient is unstable, if the disease is involving the main vessel, if the patient is not likely to survive because of the SCAD, then emergency procedures such as the percutaneous coronary intervention, that is what we do with the wires and balloons, or even a coronary artery bypass graft surgery may be needed to prevent death or bad outcomes in these patients. Some of the spontaneous dissections resolve themselves, and that may be the right way to treat it. Here in the diagram, in the coronary angiogram, you can see that the coronary artery looks normal all the way, the other coronary arteries look normal, and then as you come down, suddenly the vessel tapers down and then dwindles down to a fine hair-like structure, and this here was a spontaneous coronary artery dissection. We also mentioned Takotsubo cardiomyopathy. The Takotsubo cardiomyopathy is a condition which is also known as the broken heart syndrome. It can be precipitated due to immense emotional distress, such as a loss of a loved one, or business losses, or even just a very fearful situation can provoke this kind of situation where all of a sudden the part of the heart muscle of the left ventricle, which is the main pumping chamber of your heart, you can see here, is not pumping. Only the basal portions are pumping. And this name comes from this appearance of this heart in this condition, which is resembling a part which is used by the Japanese people to capture octopuses, where the neck of the part is very narrow and the further part down is all wide. So here, this represents a Japanese earthen pot to capture the octopus. So this is known as Takotsubo cardiomyopathy. Most of the time, the Takotsubo cardiomyopathy, the function recovers, the pumping action of the heart gets better, but certain situations happen where the patient may be extremely sick, they may be in a condition of shock, and if appropriate treatment is not provided to support their body because the heart is so weak, they may have an adverse outcome such as loss of life. Therefore, this Takotsubo cardiomyopathy should also be taken very seriously. They may present to the emergency room with ST elevations on the EKG, and when you do the angiogram, the arteries may be completely normal, but they have to be treated appropriately to get over this acute phase where they could have a bad outcome. So just summarizing, we talked about the plaque erosion, the plaque rupture, coronary artery spasm, spontaneous coronary artery dissection, microvascular disease, Takotsubo cardiomyopathy, as the various mechanisms of heart attack in women, both in the presence and absence of the plaque. Moving on, we can talk about some of the cardiovascular risk factors. And going back to the previous slide, here's a nice description of the traditional risk factors, which include the age, depression, hypertension, smoking, diabetes, chronic kidney disease, and obesity. But there are also specific risk factors which are particularly pertaining to the women, which include pregnancy, menopause, oral contraceptive therapy, preterm delivery, hypertensive disorders of the pregnancy, gestational diabetes, certain autoimmune diseases, and breast cancer treatment. The InterHeart study showed that there were identified 9 potentially modifiable risk factors. So again, certain risk factors are modifiable and non-modifiable. And among the modifiable risk factors, smoking, hypertension, diabetes, the waist to hip ratio, dietary patterns, physical activity or inactivity, alcohol consumption, plasma apolipoproteins, and the psychosocial factors, they account for 96% of the population attributable risk for MI in women. And it has been found that almost 50% of the women have clustering of more than 3 metabolic factors for the ischemic heart disease. Cigarette smoking is the single most important preventable cause of heart attack in women and a leading cause of heart attack in women less than 55 years of age, increasing their risk 7-fold. So the triad of tobacco smoking, dyslipidemia, and familial coronary heart disease is common in young patients with a heart attack. Hypertension. Hypertension is the major risk factor for heart attack in women. And this is a condition that can be so easily diagnosed that all you need to do is to see your physician, have your blood pressure checked, or buy a machine for yourself, which is easily available, and monitor your blood pressure. The hypertension is more strongly associated with heart attack in women compared with men. Dyslipidemia, always the blood cholesterol level should be checked. The total cholesterol, the low density lipoprotein, LDL levels, the HDL levels should be carefully assessed, as these are also modifiable by medications and can help in reducing the heart attack. Obesity and type 2 diabetes. About 1/3 of the women in US are obese, and 7% are extremely obese, defined as a body mass index of greater than 40 kilograms per meter square. So obesity is especially prevalent among Black women. Obesity is a major risk factor for heart attack in women and increases their risk of heart attack by threefold. So the risk of heart attack associated with the metabolic syndrome is higher in younger women than any of the other groups, increasing their odds of having a heart attack almost fivefold. Diabetes related to obesity and the metabolic syndrome is associated with a higher relative risk of coronary event in women as compared to men. Diabetes is especially a powerful risk factor in young women, increasing their risk of coronary heart disease, including the coronary syndrome, by 4 to 5-fold. Depression and the psychosocial risk factors. Now, the differences between men and women and the way they are exposed to the psychosocial risk factors and the depression is obviously very different. And depression has been shown to be a very important contributory factor as a risk factor in coronary heart disease. Moving on, the depression in women is a powerful predictor for early onset of heart attack and showing a more robust association with heart attack and cardiac death in young and middle-aged women than in men of similar age. Again, this is a nice summary slide for the cardiovascular risk factors. Here you can see on the top left, the traditional risk factors we mentioned, other risk factors that are in particularly associated with pregnancy, outcomes, autoimmune disorders, chronic kidney disease, chest wall radiation, cardiotoxic chemotherapy for cancers, and hormonal factors such as the premature menopause hormone therapy, polycystic ovarian syndromes, obesity, and cardiometabolic risk. In combination with the social determinants of health such as the race and ethnicity, education, income level, and psychological risk factors including depression, loneliness, perceived stress, they all contribute to inflammation, and this affects the heart in the way that you get predisposed to myocardial infarction, heart failure, stroke, and sudden cardiac death. Moving on, in terms of symptoms of the heart attack. Now, many times we get asked this question whether the symptoms of heart attack in men and women are different. And sure, there are some differences between the way men and women present. This table nicely shows what are the typical symptoms where the patient can have chest pain or discomfort, which is a central substernal chest pain, which is described as pressure type or tightness or squeezing. And the atypical part of that would be that the chest pain is sharp, burning type, aching type, soreness, or reproducible. And many times if we touch and the patient gets chest pain, which is reproducible, we tell them, well, this is not likely to be your heart because it is reproducible, or if it is sharp, or if it changes with your respiration, where it is known as the pleuritic type of chest pain, we tell them this is not your heart. But we have to pay attention that these features in women may actually be representing chest pain coming from the heart. When you have other symptoms, they are known as the associated symptoms that are associated with the heart attack. So you will see symptoms such as unusual fatigue, unusual shortness of breath, upper back pain, back pain, pain on the neck, jaw, arm, shoulder, and epigastric pain. These are all associated symptoms with the heart attack. Sometimes women may present with flu-like symptoms, dizziness, generalized stress, or impending sense of doom that something bad is going to happen, generalized weakness, indigestion, palpitations. These are all the associated symptoms. Now, in women, one has to be careful because many times they will present as the associated symptoms as the predominant symptom. So a woman may present to the emergency room and say that she is short of breath, or the fatigue is extreme and she's not able to do what she has been able to do all other days. And they always try to give you these associated symptoms as the presenting symptoms, and the chest pain may be lower down on the list. So if we ask them, do you have chest pain or do you have chest discomfort? And majority of the time, the answer will be yes, by the way, I have some chest pain too. So this is an important reason where there can be misdiagnosis, and the physician may start thinking of other possibilities, saying that this is not your heart. And this can also be the reason for delayed revascularization and higher heart attack rates and higher death rates associated with the heart attack, because so much time is already lost before things could be done. Compared with men, women are more likely to have high-risk presentations and less likely to manifest mainly as a central chest pain. Another feature is that shoulder pain and the arm pain are twice as predictive of an acute coronary syndrome diagnosis in women compared with men. So coronary angiography is usually less often performed in women, largely because their risk is underestimated, and yet women have significantly higher mortality rates than men, regardless of the age. What accounts for this excess risk is unclear, but the absence of chest pain may be more predictive of mortality in the younger women with heart attack than similar age groups. There are a lot of reasons for delay in presentation. And in one of the studies, they show that women, the median delay was almost 54 hours from the onset of symptoms. And in men, this was shorter to about 16 hours. Delay in seeking medical care for symptoms contribute to poor outcome for women. Additional factors that cause delay in the presentation include older age, female sex, Black or Hispanic race, lower education, and lower socioeconomic levels. Having a history of heart attack, angina, diabetes, hypertension, heart failure are also associated with the longer treatment-seeking delays. Living alone, interpreting the symptoms as non-urgent and temporary, consulting with a physician or a family member, fear, and even embarrassment also lead to delayed treatment and delay in seeking help. This is again a nice summary slide to see what should be the approach when women present with chest pain. And here, in addition to the primary symptoms, they are more likely to experience the atypical symptoms or the associated symptoms. One should consider the racial and the ethnic perceptions. One should also take into account the psychosocial or psychological stressors, and then keep in mind the other possibilities such as spontaneous coronary artery dissection, MANOCA, or coronary artery spasm. So what is a coronary angiogram? Because we've been saying that you should perform the coronary angiogram. So coronary angiography is a procedure where a small tube is advanced from the artery in the groin or from the wrist, and the tube is then advanced into the mouth of the artery, and iodine contrast is injected into the artery, and then X-ray pictures are taken, which then shows the artery, and when there is a narrowing, it will show as a pinching of that segment of the artery. Again, a cartoon demonstrating the injection of the contrast in the coronary arteries. This artery on the right is the right coronary artery, and this one on the front is the left anterior descending artery. So here you can see that the contrast is pinched. There's about 85% blockage here, and that is due to the atherosclerotic plaque over there, which was causing the contrast to be pinched on the X-rays. Now, what is angioplasty is if you introduce a wire into that vessel and then advance a balloon on which a stent is crimped, and you expand the balloon, then the stent gets expanded and gets embedded into the wall, opens up the artery, the balloon can be deflated, the wire can be removed, and then you're left with the stent in the artery, which keeps the artery open. This is known as angioplasty and stenting to open up a blocked artery. Here's a diagram which shows that The microvascular bed is also very important, and coronary microvascular disease, particularly in women, is a very important factor that should be considered when they have recurrent chest pains. There are other things that can be done when there's a lot of calcification within the artery, and the balloon that we put there cannot be expanded appropriately because the calcium acts like a rock in the vessel and you cannot expand your balloon. And in that case, you can do something which is known as orbital atherectomy, where there's a wire, and on the top of the wire, there's a small metallic ring, and on top of the ring, you have some diamonds embedded onto the structure. And when it spins at a high speed, it shaves off the calcium from the vessel wall. And then you can see that if you rotate it at a higher speed, you can get better lumen of the vessel. And now, because the calcium has been removed from the top surface, you can easily introduce your balloon there and expand the balloon, which allows full expansion of the balloon. And then you can put a stent in that vessel. And because the calcium has been removed, you can get a good expansion of the stent, which then gives a good outcome in terms of flow to that part of heart muscle. And also a good expansion of the stent prevents re-narrowing of the stent and other complications such as clotting of the stent when the stent was not fully expanded. Other things that we can do in the cath lab is, particularly if you get re-narrowing within a segment which was stented before, this is known as restenosis. And with the help of a laser, you can burn off the tissue, which allows to expand the balloon well and put another stent within the stent. And this is known as laser atherectomy to open up clogged vessels. Here's another cartoon which shows that, where the laser is able to remove the tissue and give a better opening. Sometimes in conditions of heart attack, the heart's function gets decreased to an extent where not enough blood can be pumped out of the left ventricle, and the circulation to the brain, the kidneys, the liver, the gut is all compromised. This condition can be fatal and occurs in patients with heart attack. Cardiogenic shock occurs more commonly in women as compared to men. And if this condition is not addressed right away, then the patient can have a very bad outcome. Death rates of up to 70 to 80% can happen. And therefore, this condition should be treated with extreme urgency as soon as the patient arrives. And if their blood pressure is low and the circulation to the body organs is low, they should be taken to the cardiac catheterization laboratory. We can introduce a pump into the heart, which is known as the impella, which sucks the blood from the left ventricle and pumps the blood into the aorta over here. And that allows the blood flow to the brain, to the kidneys, to the liver, to the gut, and helps to maintain the perfusion to these organs, which gives the patient a better chance of survival with intact organs. And you immediately perform coronary angiography, and you find blocked vessels. You try to improve the blood flow by either doing angioplasty or stenting, and also in some cases sending them from an emergency coronary artery bypass graft surgery. Here at San Antonio Community Hospital, we are able to deal with the cardiogenic shock. We have a shock team where we work closely with our colleagues from the emergency room, from the pulmonary department, with the cardiothoracic surgeons, and we all come together at any hour of the day as a team to help this patient in cardiogenic shock so that we can protect their organs and prevent death or bad outcomes in these patients. We are fortunate that we can provide these services at the San Antonio Community Hospital, or now the San Antonio Regional Hospital. This is what is known as the IVUS, and it's a catheter which allows us to do the ultrasound of the arteries from within. And it's very important nowadays that we do the stenting with the help of the IVUS, because the IVUS catheter gives us an appropriate measurement of how big the artery is, how long the lesion is, and then you can decide to put an appropriate length and width of the stent in the vessel with the help of the intravascular ultrasound. And even after the stent is being put in, then we can check with the help of the ultrasound whether the stent that you put in has been appropriately placed, that there are no tears in the artery at the edges of the stent, and the stent has well expanded. When you do the IVUS guided stenting, then there are better outcomes over the long period of time. There are lesser chances that the stent will clot. There are lesser chances that the stent will reach the nose. And therefore, it is very important to do the IVUS guided stenting at this day and age. And then we are able to do this at the San Antonio Regional Hospital. And we routinely perform IVUS measurements on the vessels and to see if we have appropriately done a proper job of putting the stents in there. So this is all about, the ischemic heart disease or heart attacks in women. Now, a very important part of the cardiovascular disease and heart attacks is cardiovascular disease in pregnancy. In fact, the cardiovascular disease is the single largest cause of maternal morbidity and death in this group of patients. So pregnancy complications, they increase the risk of cardiovascular disease later in life. So if a patient has conditions such as preeclampsia, gestational diabetes, gestational hypertension, later on in life, these patients are likely to develop their heart attack at an earlier age, much before than their counterparts. Increased risk of cardiovascular disease has also been described for fetal complications, such as if there has been a preterm birth, if there has been a small for gestational age, if there has been a stillbirth, then these factors also predispose a woman to earlier coronary events. And therefore, when we take the history on these patients, it's very important to address and find out whether they had these issues, such as the maternal factors, such as the hypertension and the factors that were affecting the babies. Pregnant women are also at 3 to 4 times increased risk of heart attack during pregnancy when compared to the non-pregnant women, particularly in the 3rd trimester and the postpartum. They are at the highest risk groups. Angiography is still the gold standard for diagnosis of ischemic heart disease in pregnancy. Pregnancy in women who have existing coronary artery disease is also considered very high risk. So here's the various mechanisms like pregnancy-associated spontaneous coronary artery dissection or an intimal tear or atherosclerosis, and MNOCA, which is myocardial infarction in non-obstructive coronary artery disease. And here's the algorithm is when you do the angiography, then if the patient has atherosclerosis, then you should do coronary intervention and put this patient on dual antiplatelet therapy. It's a difficult concept to put together in the sense that you have a woman who's pregnant and now they are having a heart attack, or they just delivered and they are having a heart attack, and you take them to the cardiac cath lab and do all these procedures. But sometimes that is necessary to do that to protect the woman's life or save the heart from getting into a large amount of damage or develop complications such as heart failure. Some of the hypertensive disorders of pregnancy, which are the preeclampsia, gestational hypertension, chronic hypertension, and chronic hypertension superimposed with preeclampsia, should be considered and appropriately addressed. Here you can see that the cardiovascular risk factor screening should be performed within 3 months of postpartum. So if the conditions such as the hypertensive disorders of pregnancy, gestational diabetes, intrauterine growth retardation, preterm birth, placental abruption, and if these factors occurred, the cardiovascular assessment of the risk factor should be done within 3 months after the postpartum period. And adequate history should be obtained, physical examination should be performed, and laboratory testing should be done for lipids and diabetes and protein creatinine ratio in the urine. And with that, I will end my talk here. And this is my dog, and I love to be with my dog outside in my backyard. And you can see he's looking out for things, so always be vigilant. So my message here is be vigilant, look out for smaller signs, look out for things that could easily be missed, and therefore protect a woman's life. And finally, be happy. That's the secret to success in life. Thank you.
Thank you so much, Dr. Mody, for that very informative lecture. We do have quite a few questions, and so we'll do our best to get to as many as we can. Some are similar in nature, so we may combine them. And if we don't get to the questions, please, to your question in particular, please feel free to email me and we'll get an answer to you as quickly as possible. One question was, at what age should women take an 81 milligram baby aspirin?
Right. So the use of aspirin should be, I think, basically divided into two parts. One is a secondary prevention. So if somebody had a heart attack or they had angioplasty performed, or they had a stent performed, those women should take aspirin 81 milligram for the rest of their life. If the woman had a stroke, or if they have evidence of carotid artery disease, or if they have evidence of peripheral vascular disease involving the lower extremities, they should be on aspirin for the rest of their life. Now, routine use of aspirin is now not recommended. So if you have a healthy person with no other risk factors and they just want to take aspirin to protect from a heart attack, that's usually not recommended. Routine use of aspirin for women who are older than 70 years of age and they don't have any other medical problems, that is also not recommended. Now, some of the situations where you could maybe use the aspirin is that if they have a high atherosclerotic risk factors, such as if they are diabetic, they have a smoking habit, they have a high ASCVD score, which is a score that is formed by putting all the risk factors together. If they have high coronary artery CT calcium score, which shows evidence of plaque formation in the arteries, and if they have a low risk of bleeding, then in those cases, the aspirin could be considered.
Thank you. The next one is, what would having a constant sharp pain in the middle of the left scapula be a sign of a heart attack in women if it occurs outside of doing exercise and is not relieved with rest or a massage?
So this again reinforces the idea that the chest pain in women can be atypical. So typically we would say if the chest pain is sharp, or if it is reproducible, or if it is an unusual location, it's not likely to be a heart, but that is not the case in women. So atypical pain, such as the pain between the shoulder blades, pain at the neck, pain at the shoulder, pain in the arm, they can be manifestations of obstructive coronary disease. They can be manifestations of heart attack, and therefore you should not ignore the symptoms and therefore seek immediate attention. EKG should be done and further appropriate testing should be done to find out whether these symptoms are related to coronary heart disease or not.
Thank you. At what age should women get screened for heart disease compared to men?
We went through the topic that younger women can have heart disease too, and it may not be typically atherosclerotic heart disease. So my suggestion would be that at any age, if you have symptoms that raise the suspicion that what we discussed could be coming from your heart, the patient should address these symptoms. Otherwise, women older than 40 should definitely get all their screening done in terms of hypertension evaluation for diabetes, their lipid profile, atherosclerotic CVD score, or which is known as the ASCVD score. There's important role of calcium score, CT calcium score, to see if they have presence of calcium deposition in the arteries. So age 40 and above would be an appropriate age to get into the screening. But any age before that, if there are symptoms there, then they should be addressed.
Thank you. Should postmenopausal women take hormone replacement therapy?
Well, that's a very interesting question, because one would think that estrogens have a protective effect in younger women, and we talked about how estrogens can be protective. But the studies have been done that giving hormone replacement therapy to patients in the postmenopausal age for the primary prevention of coronary disease or for the secondary prevention of coronary artery disease has not really resulted in good outcomes. In fact, there have been adverse outcomes by giving the hormone replacement therapy to such women, and therefore at the current time the hormone replacement therapy is not recommended for women for coronary artery disease prevention.
Yeah. What should I do if I think I have symptoms but I'm not sure?
Oh, that's an excellent question. And that really focuses on and highlights the whole topic that women, they have to, first of all, take it upon themselves to say, well, this could be a heart problem. They have to take the initiative. They have to seek help. And then the second message goes out to all of our colleagues in the emergency room and other physicians that when women present with atypical symptoms, then they should not be dismissed and they should not get sidetracked by thinking, oh, this could be gastrointestinal or that could be something else. And therefore, the message is that, the women should take it upon themselves. They should insist on being taken care of. The physicians should do the appropriate testing for cardiac evaluation to make sure that these symptoms are not produced because of coronary artery disease. And those are the important messages that I would like to give, that it's both on the women and the physician and the system, such as the emergency room, to not dismiss the symptoms and pay attention and do further investigation to make sure that these are not associated with the coronary artery disease. Thank you.
And we'll ask just a couple more questions. How important is it to take a statin?
Again, an excellent question, Allison, and really those are all the questions that are very important. There is a lot of hype in the media, and obviously there are groups that are pro-statins and there are groups that are against statins, and there's so many articles written down. And on Google, you can find that so many articles are written which lead to misinformation and sometimes good information. But I would again break it down into two groups. Like if somebody had a heart attack, or if somebody had a stroke, or somebody has established peripheral vascular disease, those patients should take statins because there is clear evidence from studies which shows that taking statins can prevent another event, another heart attack. They can prevent another stroke. They can prevent deterioration of the peripheral vascular disease. So those patients should take statins. Patients who have diabetes, they are considered to be at a very high risk of these coronary events such as heart attack, stroke, loss of limb from peripheral arterial diseases. So patients who are diabetic, no matter what their cholesterol levels are, they should take the statins. There's another group of patients where we call what is known as the atherosclerotic cardiovascular disease score. And this is a scoring system where you take into account the patient's gender, patient's sex, the age, the race, the hypertension, whether they're on treatment for hypertension, whether they have diabetes, what is their lipid profile, what is the LDL level, what is the HDL level, and whether they're smoker or non-smoker. And you put all this together and come up with a composite score. So if their score is greater than 7.5 at a 10-year risk, then it is considered that they are at a higher risk of these events. And therefore, patients with the ASCVD score of greater than 7.5% should take these statins. And the fourth group of patients are those patients who have familial hypercholesterolemia, and usually these patients will have their LDL cholesterols greater than 190. So even if they had no event, if they have LDL cholesterols greater than 190 and they have familial hyperlipidemia, they should take the statins. So those are the four major groups of patients who should be taking statins. There's some evidence that if you have high calcium score and higher risk profile for cardiovascular disease, then statins may also be helpful in those situations. Thanks.
Thank you. Are there certain life situations among women that can exacerbate the risk of a heart attack?
Right. So going back to one of the topics we discussed is pregnancy. And many times you think, oh, woman is in a childbearing age, she's young, she just had a baby, or she's going to have a baby. There's no way she can have a heart attack. Cardiovascular disease is the least priority that can be put at their minds at that time. However, it is important to know that the major cause of death in pregnant women is cardiovascular disease. So pregnancy is a unique situation, younger women, childbearing age, and they should always be considered if they're having symptoms that are suggestive of coronary artery disease, that they should be evaluated for those. They may not have the typical atherosclerotic plaque, but they could have other reasons that could cause heart attack and that could cause death.
All right. And our final question is the risk for heart attack higher if you have a heart murmur and have been told the murmur is not a concern?
Again, interesting question. And thank you for that question. And we get asked this question many times in our offices where we get a patient referred to us because a murmur was heard. So typically, a murmur is produced because of the problems with the valves in the heart. So either the valve is too narrow or the valve is leaky and is not closing appropriately. And typically, the finding of such murmurs is not an increased risk factor for heart attack by itself. Many times there can be some confusion between heart attack and heart failure. And it is important to know that if you have a significant valvular heart disease, such as aortic valve disease or a mitral valve disease, then it should still be addressed appropriately, because if those are not appropriately addressed, there can be increased risk of heart failure and adverse outcomes in terms of conditions such as development of pulmonary hypertension, which can affect the quality of life as well as the survival. So heart murmurs don't increase the risk of heart attack. Heart murmurs come from valves and could cause heart failure and other reasons for decreased survival.
Well, thank you again, Dr. Mody, for all of this wonderful information. And I'd like to thank you all for joining us this evening. We will have another lecture next week, so we hope to see you then. Have a great night and be safe.